Welcome to the deep dive. We've got some really comprehensive revision notes here, and today we're focusing on Edwards syndrome, also known as trisomy 18.
That's right.
Our mission, as always, is to break this down into something clear, high yield, and hopefully memorable for your learning.
Absolutely. Think of this as cutting through the noise, getting straight to the crucial bits of Edwards syndrome for effective revision. It's dense stuff, but we'll make sense of it.
Great, so let's start right at the beginning. Edwards syndrome. What is it, fundamentally?
Okay, so simply put, it's a genetic disorder. It happens because there's an extra copy of chromosome number 18 in the cells.
An extra chromosome 18.
Exactly. And this extra genetic material, well, it causes pretty significant problems. We're talking severe developmental issues and various malformations in different organs.
And how does that extra chromosome actually get there? Is it something inherited, passed down?
Yeah, good question. Mostly, no. It's typically caused by a random error when the egg or sperm cells are forming. It's a process called non-disjunction.
Non-disjunction.
Right, where the chromosomes don't separate properly. So one of those reproductive cells ends up with an extra chromosome 18 by chance. It's really key to remember this isn't usually inherited. It's spontaneous for that specific pregnancy.
Okay, spontaneous. But are there things that make that random error more likely? Any risk factors we know about?
Yes, there are a few. The big one is advanced maternal age. As women get older, the risk of having a baby with trisomy 18 does increase.
Right, the notes mention this maternal age effect. What's important about that specifically?
Well, the risk stays pretty stable until a woman hits about 30. But after that, the chance of a live birth with trisomy 18, it exponentially increases.
Exponentially, wow.
Yeah, it peaks around age 45 and then sort of levels off. So while it can happen at any age, the probability really climbs later on. There's also, interestingly, a slight positive link with advanced paternal age, but it's much less pronounced than the maternal age effect.
And why is that maternal age effect thought to happen?
One of the main ideas relates to older eggs, the oocytes. There's just a higher chance of that non-disjunction, the faulty chromosome separation, happening in older eggs.
Okay, makes sense. So we have this extra chromosome 18. What does it actually do wrong developmentally?
Basically, having that extra chromosome just throws a wrench in the works of normal development, right from the very beginning. All the genes on chromosome 18 get overexpressed.
Too much gene activity.
Exactly.
Yeah.
And that imbalance sets off this cascade, leading to all the structural problems, the functional abnormalities, the organ malformations we see in Edwards syndrome.
The notes also mention different types, full, mosaic, partial trisomy 18. What's the difference there?
Good point. It's about which cells have the extra chromosome 18 and how many. Full trisomy 18 is the most common, maybe 94% of cases.
Okay.
In that type, every single cell in the body has the 3 full copies. Then you've got mosaicism, maybe 5% or so.
Mosaic, like a pattern.
Kind of, yeah. Only some of the body cells have the extra chromosome. The effects can be variable, sometimes milder, depending on which cells are affected and how many.
And partial.
Partial trisomy 18 is pretty rare. That's when only a segment of chromosome 18 is triplicated, so there are 3 copies of just a piece of it. This often happens because a parent carries something called a balanced translocation.
Balanced translocation. What's that?
It means the parent has their chromosomes rearranged, but it doesn't cause them any problems because all the genetic material is still there, just in a different order. But it can lead to their child getting an extra or missing piece of a chromosome.
I see. Okay, so if doctors see some of these features in a baby, what else might be on their minds? What other conditions look similar? The differential diagnosis.
Yeah, really important for diagnosis. There are definitely overlaps. You'd think about trisomy 13, which is also called Patel syndrome. Same condition, 2 names.
Right, trisomy 13, Patel. Got it.
Also trisomy 21, Down syndrome, of course. Then there are others like Pennish-O'Care syndrome, type 1, conditions involving fetal akinesia sequence, basically, lack of fetal movement, and charge syndrome.
Ah, charge. That acronym pops up a lot. Can you quickly remind us what it stands for?
Sure. C is for coloboma, an eye defect. H for heart defects. A for atresia of the choanae, blocked nasal passages. R for restriction of growth and development. G for genitourinary abnormalities. And E for ear anomalies.
CHARGE.
Okay. And beyond that, you'd consider other general chromosomal issues or, various other syndromes that involve congenital malformations.
That's quite a list. Any quick tips for keeping the main trisomy straight?
Well, focusing on the chromosome number helps. 13, 18, 21. Remember, trisomy 13, Patau, often has more severe brain defects, and things like cleft lip and palate can be more common or pronounced than in trisomy 18. Trisomy 21 Downs usually has those distinct facial features and hypotonia, that low muscle tone.
Okay, helpful distinctions. Let's talk numbers. How common actually is Edwards syndrome?
In the UK, it's estimated around 1 in every 5,000 live births. Globally, maybe closer to 1 in 6,000 live births overall. That makes it the second most common autosomal trisomy we see after trisomy 21.
Second most common after Downs.
Right. But you have to remember, these live birth figures are affected by prenatal screening. Many cases are diagnosed before birth, and sometimes termination is chosen.
Okay.
And here's an interesting fact. More infants born with trisomy 18 are female.
Really? Why is that?
The thinking is that male fetuses with trisomy 18 might be more vulnerable, maybe more likely to miscarry or be stillborn, some kind of selective pressure.
Fascinating point. So clinically, what are the absolute key features you'd expect to see in a baby with Edwards syndrome?
Well, severe intellectual disability is unfortunately a constant feature, and then there's a whole constellation of congenital malformations. Really key things to look for are heart defects, problems with brain structure, and those very characteristic clenched fists.
The overlapping fingers.
Yes, exactly. The second and fifth fingers overlap the third and fourth. That's a classic visual. And also rocker bottom feet, where the sole of the foot is rounded.
Okay, clenched fists, rocker bottom feet. What else?
They often have low birth weight and just don't grow well. You might also see micrognathia, a small jaw, low-set ears, and microcephaly, a small head.
And can these things be spotted before birth? What's the typical antenatal picture?
Yes, absolutely. Antenatal screening picks up many cases. Ultrasounds in the first trimester might show increased noodle translucency, that fluid at the back of the neck, or an absent nasal bone.
Right.
They might also see abnormal blood flow patterns, like reversed flow in a vessel called the ductus venosus, or tricuspid regurgitation where a heart valve leaks.
Okay, so signs on the scan. Anything else?
Yeah, later on you might see growth restriction, too much amniotic fluid, that's polyhydramnios, skull shape abnormalities, obvious heart defects, or sometimes an omphalocele.
Omphalocele. That's where the organs are outside the abdomen.
Yes, protruding through the navel area, covered by a membrane.
Okay. And then after birth, the postnatal presentation. What confirms the suspicion?
Postnatally, low birth weight is almost always there. The cradiofacial features we mentioned, low-set ears, small jaw, maybe a cleft lip or palate. And the skeletal signs are really key. Those clenched hands with the overlapping fingers really burn that visual into your memory, and the rocker bottom feet.
Got it. Hands and feet.
And heart defects are incredibly common, over 90% of cases. Things like holes between the heart chambers, ASDs and VSDs.
Okay, heart defects are major.
Definitely. Then you can see gut problems like omphalocele or hernias, urogenital issues too, problems with gonad development, undescended tests in boys, kidney abnormalities.
A lot of systems affected.
Yes. Neurologically, besides the learning disability, which is universal and severe, you can have structural brain problems, seizures, and underdeveloped lungs. Pulmonary hypoplasia is another serious issue.
Wow, that is a lot to keep track of. Any way to maybe group those postnatal findings?
Yeah, maybe thinking system by system helps. You could use like the 5 H's and 2 G's, perhaps. Start with heart, nearly always affected.
Yeah.
Head, the craniofacial features, hands and feet, clenched fists, rocker bottom. Then gut, omphalocele, hernias, and genitals, the urogenital problems. Does that help structure it a bit?
Heart, head, hands, feet, gut, genitals. Yeah, that actually does help break it down. Thanks. So how do you get that definitive diagnosis? What are the crucial investigations?
The gold standard is chromosomal analysis. That means looking directly at the chromosomes. You can do this with karyotyping, which gives you a picture of the chromosomes, or a chromosomal microarray, which is even more detailed.
Karyotyping or microarray.
Right. Antenatally, as we said, ultrasound raises suspicion. And then genetic counseling and testing are absolutely vital, both to confirm things and support the family. After diagnosis, you'll do organ-specific checks based on what you find, like an echocardiogram for the heart, kidney ultrasound, and so on. It's very much a team effort managing these cases.
A team effort. So once it's confirmed, what does management look like for a baby with Edwards syndrome?
It absolutely has to be a multidisciplinary team. Genetics, neonatology, cardiology, neurology, surgeons, palliative care, everyone working together. The main approach is supportive care.
Supportive care, meaning?
Meaning you tailor the care to the baby's specific needs, focusing on comfort and quality of life. Surgical interventions might be discussed for very specific, life-threatening things like certain heart defects, but it's a complex decision.
Okay. And what specific supportive things are typically needed?
Managing feeding difficulties is common, sometimes needing tube feeding, dealing with the heart problems, maybe with medication or sometimes surgery, assessing breathing problems, perhaps needing sleep studies, checking vision and hearing, monitoring the spine for scoliosis, looking at the kidneys with ultrasound. There's even screening needed for certain abdominal tumors if the child survives longer, and ongoing neurological and developmental support, of course.
It sounds incredibly complex and demanding. Sadly, we know the prognosis is often very difficult. What does the data show about outcomes?
Yes. Unfortunately, the overall prognosis is poor, very poor. Most infants don't survive their first year. The median survival time is only about 14 days.
Just 2 weeks.
Yeah, maybe 20% make it to 3 months, and only around 8% reach their first birthday. The main reasons for death are often central apnea, breathing just stops, cardiac failure from the heart defects, or respiratory insufficiency because of lung problems or infections.
That's incredibly tough.
It is. And it's worth noting that how we approach neonatal resuscitation is evolving. There's much more focus now on discussing things openly with parents, respecting their wishes, considering the likely prognosis.
Right. Does intensive care make a difference?
Sometimes. Intensive care, including things like heart surgery, can extend survival for some. But again, these are very difficult conversations and decisions for families and medical teams. Screening and counseling beforehand are so important for informed choices and support.
And does it have implications for future pregnancies?
Yes, especially if the cause was that rare partial trisomy due to a parental balance translocation. In those cases, the recurrence risk is higher. Also, it's interesting that the standard serum screening tests for Down syndrome risk can also flag an increased risk for trisomy 18. And ultrasound, as we said, often spots those structural clues.
Okay. And finally, just to summarize the common complications that these individuals face.
Sure. The big ones are severe intellectual disability and developmental delays, major heart defects and other structural problems, significant feeding difficulties, breathing issues, vision and hearing impairments. They're often more susceptible to infections, and, as we've discussed, a greatly shortened lifespan.
So pulling it all together, Edwards syndrome, trisomy 18, it's this serious genetic condition, extra chromosome 18, leading to really widespread developmental problems, multiple physical abnormalities, and a very challenging prognosis. We've covered the cause, usually random, the main risk factor being maternal age, how it affects development, the key clinical signs like the clenched hands and heart defects, how it's diagnosed and managed supportively.
Exactly. We wanted to give you that clear, concise overview, hitting the high-yield points for your revision. It's a tough topic, medically and emotionally, but hopefully this conversation has made the core information more accessible and easier to recall.
Absolutely. It really underscores the complexity of genetics and the immense challenges involved. For anyone wanting to delve deeper or find more revision resources, do check out passthemsra.com and also freemsra.com.
Yeah, definitely useful resources. And, exploring Edwards syndrome really is a stark reminder of just how intricate our genetic blueprint is and how profound the impact of even one extra chromosome can be. It highlights the vital importance of ongoing research, but also, crucially, of compassionate care and support for affected children and their families.